webinar series. We're excited to have over 480 registered attendees for today's webinar. I want to remind you today's webinar is eligible excuse me, for one continuing education hour. Let's kick off today's webinar by giving away an OR Today live surprise pack to the attendee that can tell me the answer to the following trivia question. February is American Heart Month, so what is the name of the first doctor to perform the first ever successful human heart transplant? Answer now using the questions feature on your dashboard. While you're answering, just a reminder to save the date for our 7th annual OR Today Live Surgical Conference, which will be taking place August the 16th to the 18th at the Omni Interlochen Hotel in Denver, Colorado. Join us to discover new opportunities, broaden your knowledge, and exchange ideas. For more information, visit ortodaylive.com. Also, this year, the World Health Organization is celebrating the Year of the Nurse. Help us celebrate by sharing a standout story about you or a nurse in your life. Each submission will be entered to win a $25 Bath & Body Works gift card. Visit ortoday.com/contest to enter. Okay, and let's see who the winner of our surprise pack is, and it is Julie Anderson. Congratulations, Julie. Of course, the correct answer is Dr. Kristen Barnard. The OR Today would like to thank our sponsor, RepScrubs. RepScrubs offers vendor management and cost reduction solutions. For more information, visit repscrubs.com. Our presenter today is Dr. John Kutz, Medical Advisor at RepScrubs. John, you may begin whenever you're ready.
Thank you, Linda, so much. I don't want to belabor the apologies for the technical difficulties, so let's just get into it. It's great to have everybody here this afternoon. As you can see, the title of my talk is OR Food for Thought, literally. What are we bringing into our ORs and why? And for those of you who may not know this, I'm actually the chairman of surgery at my hospital, so this is something that I hold near and dear to my heart. And earlier this morning, I was at a meeting with the Joint Commission who came to our hospital to do their survey. So anybody who is in an OR every day can understand what this title means. So let's get started. So I put this slide on here, and I want you to kind of keep it in the back of your mind as we go through the rest of the talk. This is semiconductor construction and processing. And whenever I see these slides, I kind of chuckle a little bit because it seems as though the attitude in this process is markedly different than it would be in an operating room. Sorry, folks. You know, you can see everybody's dressed to the hilt. It's an absolutely pristine environment. There's nothing on the floor. People have gloves on. Their hair is covered. They have masks on. And the seriousness with which we approach this seems markedly different sometimes than what the operating room is. So keep this image in the back of your mind as we kind of progress through the talk. For those of you who have participated in my previous webinars, I put this slide in each one, and it's really to create a little bit of perspective for you as we march forward. This is the first operating theater in the entire United States of America. This is at Pennsylvania Hospital of the University of Pennsylvania, and this is where I did my fellowship. And if you look closely at the photo, the light that's in the center really wasn't there originally. There is a huge skylight, which provided light for them to operate, which they principally did during the day. If you see the table in the center, that's how operating tables used to actually be. They were just a flat, long wooden table. And then you can see around the back of the table, there's almost an audience type environment where people can come and stand and watch. And I think part of the issue with the operating room rests in the fact that the culture for operating room behavior really started in 1801. I mean, this was an open theater. People came and went, and they participated in, observed, and critiqued surgery. And as we go forward, you'll see how I think this is a critical moment in this whole process. So this is 1801. You know, now operating rooms are incredibly complicated environments. You can see there's a hybrid OR here, a robotic OR, and up at the top is pretty much just a general OR. But if you look at the complexity of the mechanics within these rooms and how it compares to the last picture I showed you, you can understand that what we do now is markedly different than what they did in 1801. I put this picture up to create more perspective. This was 1875, and for the art fans in the audience, Thomas Eakins was one of the most famous American artists, and he painted this at Jefferson Medical College. And this is Samuel Gross, who was the first chairman of surgery at Jefferson. And he's operating once again in an open public forum. If you look around, you can see there are people in the audience. They're operating in tuxedos. There are people in the doorway. The patient's family member is at the bedside. You know, it's a completely open atmosphere. It's almost as though this was entertainment. You know, even though we're operating on people, it almost seems to be a venue. So I thought, you know, it'd be important to highlight the operating room personnel, and really things haven't changed. If you look in the late 1800s, you had the surgeon, you have an anesthesia provider, you have students, you have an attending nurse, an audience. And today it's kind of the same. I mean, we have a surgeon, we have an anesthetist, often there's an assistant, almost always students, a circulating nurse, one, occasionally two, depending on the complexity of the procedure, and often a device or vendor representative. I mean, today's procedures involve implanting prosthetics of the highest volume that we ever have in the past. So often there's a device or vendor representative to help us perform that component of the procedure. I put up a schematic of the operating room for those people who aren't in an operating room every day. And I put red arrows just to highlight some of the titles on these buildings. You know, you see operating room, clean corridor, semi-restricted core, staff entrance. As an aside, I still don't know what semi-restricted core means, but I've been in an operating room almost 25 years. Clean room, staff change room, staff lounge area. And you know what I wanted to point out is that there are a lot of different rooms with a lot of different names and a lot of opportunities for a lot of people to be in the operating room. The clean corridor theoretically is supposed to be a hallway between the operating rooms, which allows people to theoretically, again, leave operating room 1 and go to operating room 3 in sterile attire and technically still be sterile as they enter the new operating room. The clean room is theoretically supposed to contain clean items, the staff change room, the staff lounge. The semi-restricted core is supposed to be that area where, you know, you're not really in street clothes and you're not walking on the street, but you're not really in the operating room yet. I think that title is a tough one. But you see patient exit. I mean, all of these entryways into this operating room are really potential areas for a lot to happen. So I put this slide in because sometimes when I'm in the operating room, I almost feel like this. You know, there are people all around, there are people talking, there's conversation. Everybody's invariably looking at their phone or showing pictures or talking about something. And oftentimes people socialize outside the operating room, so they're talking about what they may have done last night or last week. And there can be a sense of this party type atmosphere. I don't mean, you know, obviously no one is having an actual party, but there's a relaxed, somewhat casual feeling. And I put this up for historical perspective. I mean, the operating room has been a place with a history of social engagement. If you look at these photographs in the top left corner, that is actually, you know, that's from the 1920s. You can see a ward service with everybody gathered around two nursing quote desks. You can see an operating room. That picture on the top row on the far right, that is actually taken from one of the first successful open heart operations performed by John Gibbon. And if you look, I mean, there are probably people in that operating room that John Gibbon doesn't even know are there. If you look in the bottom left-hand corner, once again, there's an audience. And interestingly, if you look at some of the members in the operating room, they don't even have masks on. The audience doesn't have masks on, and they're more than likely in the clothes they were wearing when they came to work. Same thing in the bottom row middle. There's an audience that, you know, people are watching an operation. They don't have scrub caps on. They don't have masks on. And then on the far right, you can see nurses gathering, likely outside the door. back in the day when it was socially acceptable and almost run of the mill to smoke. And I think that is where all of this culture begins. And I think when you look back to try and figure out why some of these things happen, there is a history of social engagement. So we have a surgeon, we have an anesthesia provider, we always have assistants, students, circulators, device and vendor reps. And you can see friendships develop invariably. You spend more time with some of these people than you do your family or spouse every single day. Lines get blurred, guards come down, complacency develops, tolerance develops, acceptance develops, and you kind of get this milieu where all of this is going on. So I don't want to take it back to that party atmosphere, but there's a lot of social engagement in these environments. And then the lines get blurred. And when the lines get blurred, culture develops. A culture of tolerance and acceptance develops. And then that becomes an instrument for resistance. So, lines get blurred naturally, culture develops, and then people are hesitant to change what they perceive as the status quo. So once again, let's go back to this slide. I mean, this is social engagement. People are engaged in work, but part of that work involves socially interacting with the people around you. It's natural. So this social arena develops. And if you look in the column on the left-hand side, these are some of the things that, as a result, invariably in this social arena start to come into the operating room. So a lot of things are practice related. For example, I wear surgical loops every day, so I bring my loops in. Some surgeons bring in cameras. For convenience, everybody has a cell phone. A lot of people bring in bags, whether it be a briefcase, a tote bag. Backpacks are ubiquitous among the device and vendor representative folks. The social people bring in pictures, whether it be on their phone, whether it be an actual picture, calendars. They'll bring in gifts at holidays, for birthdays. Food is ubiquitous in the operating room lounge. Pediatrics, comfort. A lot of times they'll let the children bring in teddy bears, blankets, toys all the time. That happens to make children comfortable and let them realize that this is an environment where they can bring something in to help them. And then, of course, surgical attire. People wear cotton caps as an attempt to individualize themselves and create some fashion. Shoes that come off the street straight into the operating room all the time. Jewelry that isn't covered up or is dangling. Sweatshirts underneath scrubs. I see it all the time. One of my surgeons does it routinely because he thinks that it's too cold in the operating room. So, if you look at that column on the left, that's a lot of stuff by one person. And if you look at all the people on the right and you do those numbers, you can see that a lot of stuff ends up coming into the operating room. So I put this up kind of to create these pictures in your mind. I mean, the cheeseburger obviously is my favorite one, but if you look, there's a surgeon wearing loops with a headlight. There's phones, jewelry, teddy bears, tote bags, drinks, cotton scrub caps, sweatshirts. You look at the dirty pair of sneakers, cameras. This is stuff that I see in procedure areas, in operating rooms every day. Now, I don't see a cheeseburger, but I see drinks frequently. I see food frequently. These are all papers that I've read on this topic as a part of my role as chairman of surgery. And if you look at some of these titles, it's eye-opening. Surface contamination in the operating room, surgical attire and the operating room, the American College of Surgeons policy statement, surgical loops worn by orthopedic surgeons, preparation of non-medical personnel in the operating room. The American Society of Anesthesia did an anonymous survey, which I'll highlight in a few slides, which will frighten most people. Cell phones as a potential source of bacterial contamination, stuffed animals, and adherence to recommendations. I think that's another real struggle in getting the culture to change, is getting people to adhere to the recommendations as they are put forward. So what do they all say? Well, I made this black and white because it's really not the zebra in the room. I mean, they say exactly what you think they would. I mean, this really isn't rocket science, although some people are trying to make it that, and you'll see that as we go forward. But the studies say exactly what you would imagine they would. 100% of laryngoscopes are infected by the end of the day. 90% of surgical loops. Let me go backwards. Let me say, I don't want to say infected. 100% of laryngoscopes have a high bacterial count on them, as measured either with ultraviolet light or culture. 90% of loops, same thing. Those teddy bears, 100%. Cell phones, 83%. So those numbers, and I don't think those numbers shock anybody because cell phones, teddy bears come from the outside world. Loops are traveling all around everywhere. And the laryngoscopes are in the room when everyone is being intubated. Here's what we absolutely know. OR traffic increases bacterial count. When people come in and out of my operating room, I cringe inside because I don't know where they've been. I don't know what they're wearing. I don't know what they've been doing. And if I'm in the operating room doing an implant, doing a prosthetic implant, I don't want that bacterial count to increase and put my patient at risk. The anesthesia paper was beyond enlightening. 25% of anesthesia providers in the room consume coffee. 20% have eaten food in an operating room. This is not the hallway or that semi-sterile corridor as you saw before. 48% talking on a cell phone, and then 45% reading a book. This isn't a book that was sitting in the operating room. This is a book they brought from home. Those numbers are astounding. They're beyond staggering. 1 in 5 anesthesia providers has eaten food in your operating room. And sometimes you don't even know it because they'll put it under their mask. It'll be a subtle thing, but there's no doubt that it happens. So what's the big issue, John? Why can't we change this? Why is it such a struggle? Why is it such a hurdle? So I have that there in all different directions because the big issue is it's hard to prove a correlation to surgical site infection as related to this behavior. Creating a prospective study may have ethical limitations. And as a result of the failure to correlate surgical site infections directly to this behavior, critics have appeared. And I just went through this in my operating room yesterday with people talking about everything. Because as I try and clamp down on this behavior, of course, everybody comes and says, wait a minute, why do we have to do that? I don't understand. People are doing this, the charts are dirty, the beds are dirty, people are dirty. And I try to explain to people that I think what we're trying to do is create a culture of best practice. But the critics nonetheless pop up. So in the University of Arizona, they actually got together, it was a bunch of otolaryngologists and did this really, really big study. And the premise of it was they just weren't happy with the fact that people were trying to change behavior in the operating room. So this quote, and I'll read it to you, and I know you can read it yourself. Any guideline imposed on a hospital or its staff that creates inconvenience, increases cost, impacts efficiency, decreases patient or healthcare provider autonomy, and or potentially increases risk for patient harm, no matter how obscure the scenario, should be based on solid experimental or epidemiological data, as well as the absence of equally safe and effective alternatives. So if you really read between the lines there, what they're really saying is, look, this decreases the healthcare provider autonomy. They've put everything else in front of it and everything else behind it, but that's what really upset them was that, look, who are you to come and say what I can or can't do? I'm a surgeon. This is the operating room. I'm in charge. I'm the boss. What they're failing to realize is the argument just seems silly, quite frankly. So this paper that they wrote, when I read it, I actually started to giggle a little bit. So they did a retrospective review with 2,633 articles. After duplicates, there were 2,014 articles. After that, they said these records are not relevant and came down to 47 articles. And then they made up a whole bunch of other stuff and said, you know what, out of that 2,633, there really are only 17 articles that we think we could include in the paper. So if 2,633 articles, but at the end of the day, they found 17 that kind of supported their argument. So this is what they said. Our systematic review found no literature supporting a causal link, suggesting that current regulations barring personal items from the OR are based on theoretical concerns or, quote, expert opinion, end quote, rather than objective evidence. Doctors comply with recommendations based in data. Therefore, regulating agencies should support well-done, prospective clinical studies to better inform the application of new policies. I don't even know how to answer that. You know, this is a group of people saying, look, we looked at 17 studies and we think this is all a bunch of nonsense. And if you want to change behavior, do evidence-based medicine and come out with a prospective study. Do something that proves to me that what I'm doing now doesn't work. And I can tell you, this is a rampant theme in the operating room environment among providers right now. They say, why do I have to stop wearing my t-shirt from home? Why can't I bring a soda back into the hallway? What does it mean? And you know, the reality is that what's happening at that moment, people can't see 2, 3, 4, 5, 6 weeks from now when somebody gets a wound infection and has to come back to the operating room, which I just did all day Tuesday on one of my patients. I operated him on New Year's Eve, and I had to take him back 2 days ago for really a catastrophic problem that related to a wound infection. So let's go back to the study. I mean, when I read that study, I literally, that's why I put it in red, in caps. I said, what? Who is going to sign up? If you're going for an operation and you say, look, our hospital is doing a double-blinded prospective study. The operating room you go into may have a bunch of bacterial-laden items in it, such as tote bags, cameras. I might eat in there. People are going to wear shoes from home, or the other operating room is not going to have any of that. What patient is going to say, you know what, I'll go in the operating room with the food in it. It can't be that big a deal. I mean, how would you even conduct it? And where do you even start? I think that's the problem, is that rather than recognizing that this is a best practice process, people are so focused on their autonomy that has blinded them to what's in front of them. And how do you know that what's happening in that operating room isn't going to impact your patient? And I'm going to touch on that in a slide or two, and I think it's something that will resonate with a lot of people. You know, the American College of Surgeons has been tepid on this. It's just somewhat disappointing because I'm a fellow of the American College of Surgeons, but and I can give you a little story. When I was a resident, the director of OR attire and cleanliness was an older thoracic surgeon who actually worked with John Gibbon on the heart-lung machine. And he felt that all surgeons had to wear bouffant caps. Scrub caps were not allowed, and all scrubs had a nylon waist at the ankle, so they weren't open at the ankle. And he believed it impacted infection. Now, he had no data to support it, but that's the way it was. So the American College of Surgeons came out with a consensus statement. They said, OR scrubs should not be worn at any time outside the hospital perimeter. Agreed. Scrubs and hats worn during dirty or contaminated cases should be changed before subsequent cases, even if not visibly soiled, or should be changed daily. And that is a strong supportive statement that says, look, if you just did an abscess drainage, you're going to go put a hip in, really you should change your scrubs and your hat. Visibly soiled scrubs from any procedure should be changed as soon as feasible and before speaking with the family. If scrubs are worn outside the operating room within the hospital, they should be covered with a clean lab coat or appropriate cover-up. Removal or appropriate covering of all earrings and jewelry worn on the head and neck. The mouth, nose, and hair should be covered during all invasive procedures, and masks should not be worn dangling at any time. So I agree with all that. And masks worn dangling, for those of you who are potentially having a JCO inspection this year, that is, JCO considers that a red item event. If they see somebody with a mask dangling, they will flag you and it will go right in that column. Hair, people with beards now should cover them up. And this is the norm. This should be our best practice. The Association of Perioperative Registered Nurses every year kind of comes out with a statement about what to do. And I think this really sums it up. And I'll read it to you. I think we should remind personnel that now is an important time to make certain that everyone gets back to basics. And really, that's what it's all about. It's about providing the best patient care. As we get into more and more complicated cases, antibiotic-resistant organisms, and new emergent pathogens, now is the time to increase vigilance and make certain that we are heading to the basic tenets we have always known about. Even though we are gaining more evidence and more clarity regarding the recommendations, the truth is they haven't really changed all that much. We've known for quite a while what's right, and now we are gaining the evidence to inform us a bit more. So, the AORN has butted heads with the American College of Surgeons a little bit in these statements because, once again, I'm going to go back, and it might seem like I'm on my high horse, but a lot of the surgeons said, hey, you can't tell me what to do. If I want to wear a scrub cap or a cotton cap, or I want to wear my clogs from the other hospital, or if I want to come in here with a sandwich, I mean, I'm the surgeon. I kind of can do what I want. And that culture, if you go back to the original slide, is from 1801. So how do you change that culture in a couple of years? It's a struggle. So this is a final thought. Recently, I was doing a radiation safety course, and I came across these two principles. And it really has to do with, it's not part of what we're talking about, but I'm going to metaphorically include it here. So when people are exposed to radiation, there's two impacts. There's what's called the tissue effect and the stochastic effect. And this is in reference to malignancy developing directly related to radiation exposure. So with the tissue effect, it's a cumulative process. Below a certain threshold, they believe nothing happens. But above a certain threshold, they believe that puts you at risk for malignancy. In my mind, that threshold in the operating room is anything that doesn't belong there, anything that's not related to the performance of the procedure. The more you bring in, the higher the tissue effect. The more things that walk in that operating room, the higher the possibility of someone having developed an infection or an untoward outcome. Now, stochastic effect is where, look, the more times you're exposed to something, the potential exists for you to develop malignancy. So it's radiation exposure. So if you get a chest x-ray once a year, the cumulative impact ultimately impacts you. So it's the stochastic effect. It's not the tissue effect, meaning it's not everything that happened all at that one time, but the stochastic effect is like being struck by lightning. So the next slide is going to explain this a little bit. So the tissue effect is when you put your hand on the stove, and we all learned when we were young, why do that? There's just no point. It's not worth getting hurt, and I know the stove is hot. And the stochastic effect is winning the lottery. So if the tissue effect is bringing things into the operating room, why would I even do it? And if the stochastic effect is every exposure places somebody at that risk, and winning the lottery is getting a wound infection, or having your prosthetic aortic implant get infected, or having your prosthetic hip get infected, the subsequent experience and cost and procedures for that patient is inconceivable. And I think part of the problem with the culture, I'm going to go back to a slide, so bear with me, and I apologize for going backwards. Part of the problem is this: people don't understand the impact of what they do every day in that operating room and how it impacts the patients on a go-forward basis. And I see this time and again. They'll say to me, "Look, what happened to that patient? I never know what happens." And they don't understand that what happens at that moment impacts that patient potentially forever. So the social engagement, and this, I don't mean to say party as in a derogatory, negative way, but this sense of this relaxed atmosphere can really impact patients as they go forward and throughout the rest of their hospitalization. So, and I apologize about going backward on that slide. So I want to thank everybody. I apologize. I know we had some technical difficulties. We kind of got off to a late start. I hope that you enjoyed the presentation, and I'm looking forward to any questions or clarify anything that we talked about.
That's great. Thank you so much, John. We do have a couple of questions, actually. What do you think is the most effective way to change behavior in reference to what people bring into the OR?
Linda, I think really the most critical, it starts from the top down. I think all organizations, if there's function, it always starts from the top down. And for me, it's our OR nurse manager and myself as the director of surgery. And then it's the independent surgeons saying, look, I want my patients to be exposed to the best practice. And if the best practice is not to bring a cheeseburger down the hall or a soda from the lounge, or to not wear the scrub cap that I just wore while I drained that abscess, and now I'm coming in to help you with your carotid, well, then I think that's what it needs to be. And it's constant reinforcement. It's time and time and time and time again. And I think that's where it starts. And then it hopefully trickles down.
Okay, great. And why are people so resistant to change the status quo?
I think it goes back to that autonomy. I think the history of social engagement and the history of people coming together for a common cause, but at the same time having their own independence, I think people get frustrated with it. I see it every single day in the operating room. I want to wear this cotton scrub cap. Why do I have to wear that, that paper scrub cap? Or I want to wear this bouffant cap. Why can't I wear my shoes in here that I've worn for the last 15 years? Why can't I bring a soda down the hallway? Or patients are dirty, they come down without a bouffant cap on. And I think, people don't realize that what their behavior, how their behavior impacts the patient care. And I think that once again comes from the top down. I think it's constant reinforcement from the directors and from the surgeons to say, look, this is what we have to do and why we have to do it. I think people will change, but it doesn't happen overnight.
Okay, and another question here is, would a universal mandate impact morale among staff members?
Linda, I think about this all the time, and it's really interesting to watch the dynamic of people in an operating room. I think I like the universal mandate for things like clothing and attire and whatnot. And if you take it back to, if you go to the corporate world, like UPS and FedEx, they all have to wear a uniform, which represents their company. And I read a paper about UPS. In the beginning, the employees weren't happy, but now this is part of their identity. They want to wear that uniform. They proudly represent UPS. If you've been in the United States Armed Forces, it's the same thing. Everybody ultimately likes to wear that uniform. They represent their division of the United States Armed Forces. They're proud of it. And I think in the beginning, people are resistant to it. But then I think as it progresses and people see this as a team effort, it's a camaraderie building process. It helps lead to esprit de corps. People get involved in it and then they like it. One of the things I did in my operating room, the staff was capable of achieving a metric that I thought was a real challenge. I put it in front of them and they did it. So I purchased all of them sweaters that were personalized with their name on it, a Patagonia sweater. And when I tell you, everybody wears those sweaters around, and it helps them create a sense of unity and involvement and inclusion. And I think the universal mandate, although some people have a struggle with it, at the end of the day, they end up liking it. And so I think in the beginning it's tough, but I'm a big proponent of it.
Okay, I haven't actually got a question here. It's a thank you from an attendee. She says, "Thank you for taking a stand. It is crazy that we even have to have this discussion. It would be different if we could correlate a direct cause and effect, but that's not possible. We must do all we can, no matter how simple, to prevent microbes from entering the OR."
Yeah, I mean, honestly, I think that sentiment is so well stated, because what frustrates me is why people don't want to commit to the best practice. And I think a lot of it goes back to this social engagement process whereby the lines get blurred, and it happens all the time. The line between the physician and the technician, the line between the technician and the staff nurse, the line between the vendor representative and the circulating nurse. Because more often than not, you're friends with these people. You live in the community with them, you do things with them, you know them, and the lines of tolerance become universal. So they'll say, well, I'm not gonna reprimand John for bringing his tote bag in because I like John and I see him 3 times a week and I don't want him to be upset with me. I think what we really need to do is say, hey, John, the tote bag just has no place here. Can you leave it out in the lounge? I know you use it a lot, but I just think this isn't the best idea. I think people will respect that. I think it's just going to take some time. It's not going to happen overnight. If you go back to the semiconductor folks, what that really, that's their job. They don't have a choice. They go to work and they say, put all this on and go make semiconductors. So we treat that semiconductor process, it almost seems as though that's more, more sterile realistically than the operating room is, which boggles my mind.
Okay, and a question here is, we have issues with our OR storing soiled mops and rags in the scrub sink areas. This is a storage of solid items in a clean area. AORN says nothing about the separation of clean and dirty, so I'm having a hard time convincing OR leadership to get the solid items out of the clean area. How do we convince them when AORN doesn't take a position on this?
Yeah, it's interesting. I sigh because I literally just left a meeting with the Joint Commission about a similar topic, because the Joint, they may not have a directive in reference to something, but somebody considers it best practice. And this is not an uncommon phenomenon. And I think what you have to do is go back to your director of OR nursing and your director of the operating room physician and say, look, this just is not a good practice. We're putting soiled items right next to the scrub sink where people are coming to prepare themselves to go into the operating room. And I think it has to go to that level, because people bring stuff to me all the time of a similar nature, and we change the directive and change the way people behave, and it works. And a lot of times, people who are on the ground, this grassroots effort is what makes the difference, because they're out there every day doing this. And so I think that is the best direction to go. People come to me all the time with suggestions, a lot of which are really, really good.
Great advice. I think we have actually, it's more of a statement than a question, but this attendee says, we rely on our surgeons for business and they do not want to change. Then I'm told, okay, I will take my case down the street. They let me do what I want. We definitely need support from specific societies. Do you agree?
I do agree. And I want to tell you, as a surgeon, when people threaten to take their cases elsewhere, it really just isn't that easy, particularly if they've been hunkered down at that facility and they're comfortable there. So I, in many ways, think it's an idle and empty threat. You never know if you can trust that. And, you say, look, but I think what you have to go back to is say to that surgeon, look, don't you want the best practice for your patient? And don't you want the best outcome for your patient? And then they're going to come to you and say, well, look, there's no data to support me taking my cheeseburger into the operating room and my patient developing a subsequent infection. And you're going to say, but would you want, let me look at it this way. When you go and eat at a restaurant, do you want the guy who's cooking your food to be eating a cheeseburger while he's cooking your food? Probably not, right? So how can you even comprehend having somebody eat a cheeseburger, and I'm using a cheeseburger as an example, but or drink a soda in the hallway and then go operate, or even have it in the operating room? It makes absolutely no sense to me. I think the surgeon who's threatening to leave, I think it's an empty threat. But what you can do is sit them down and talk to them, which I have done with many surgeons, and I just did it yesterday with a surgeon wearing a sweatshirt under his scrubs, and try to explain to them the point. Really, what we're trying to accomplish here is a best practice. If that doesn't work, then obviously you're going to have to take it to the director, your physician director of the operating room. And at the end of the day, what I say is, look, if I'm going to have people in my operating room who aren't going to do what is in the best interest of the patient, then maybe I don't want them in my hospital, because it's going to impact my potentially post-operative surgical site infection rate. It's going to change morale. It's going to ask other people are going to come to me and say, why can't I do what he's doing? And it's disruptive. So at the end of the day, I say to people, look, if you want to take your case somewhere else, that's fine. I do understand the volume. I do understand the revenue, but at some point the rubber has to hit the road.
Okay, great. One more question here is, so we should look into disposable scrubs for vendors then?
Yeah, absolutely, of course. I mean, I think disposable scrubs for vendors is an absolute answer to a big problem, right? I mean, the vendors come in oftentimes in scrubs that they've laundered at home, which the AORN has a statement that you cannot launder scrubs at home. It's not regulated, it's not efficient, it's not proper and it's not hot enough. So the AORN has a statement on that. So they come in often with their scrubs laundered at home. They've almost assuredly been in multiple other facilities. They've been in and out of their car. They walked right into your OR in those scrubs, without a doubt. Those people absolutely need disposable scrubs. Those disposable scrubs place your patient, create a higher, let me rephrase that. Those disposable scrubs make a safer environment for your patient and decrease the risk for them to have a potentially adverse outcome.
Okay, that's great. We don't appear to have any more questions. Oh, hang on a minute. No one's just popped in. What should we do, or how can we prevent staff from slipping back into bad habits?
It's so funny you say that. I just went through this. Our director of OR nursing left, and we had a transition until we filled that role. And a lot of those bad habits crept right back in, partly because I can't be there 24/7, but the OR nurse manager is, and it requires constant vigilance and constant attention and constant reminding. And I think people are receptive to it when you say, look, can you please not come into my operating room and create traffic? I'm putting in an aortic implant. Or can you please make sure we do this because we're really trying to do what's best for the patients. I think when people are confronted with it initially, they take it as you're threatening my independence and autonomy. But I think if you flip it and say, look, what we're really trying to do here is take care of the patients. And bringing your tote bag down the hallway, although it's convenient for you and it might make life easier for you, it might put the patient at risk. So why don't we do what's best for the patient? That's my attitude. And create areas in the operating room that are for those semi-restricted corridors, those staff changing areas where they have opportunities to put things on the floor. They can store them. They're accessible, but not in the clean component of the OR, so to speak.
Okay, that's great, John. Looks like there's no more questions, so we'll wrap up now. So thank you again, John, for a really informative webinar, and obviously thank you again to our sponsor, RepScrubs. We do apologize once again for the earlier technical issues and hope it didn't spoil it too much for you. Just a reminder that the post-webinar survey and certificate process is automated, so the survey link will be included in the follow-up email, which you'll receive in about an hour's time. Once you've completed the survey, you'll be able to download your certificate immediately. If you have any questions, please contact us at webinar@mdpublishing.com. And for more information on our upcoming OR Today webinars, please visit our website, ortoday.com. Thank you once again for joining us. Enjoy the rest of your day, and we hope to see you next time.
Thanks, Linda. Thank you for having me.